Hello and welcome to this Clinical Care Options Oncology podcast. I'm your host, Jerfis Constanzo. In today's episode, we're joined by Dr. Stephanie Graff from Brown University Health Cancer Institute in Providence, Rhode Island, and Dr. Laura Spring from the Massachusetts General Hospital in Boston, Massachusetts. Together, they will be discussing the current therapeutic landscape and emerging new data for novel treatment options for HER2-positive, newly diagnosed metastatic breast cancer. This episode is part of a larger educational program entitled Advancing Precision Care and Shared Decision-Making in First-Line HER2-Positive Metastatic Breast Cancer Management, Expert Insights, Patient Resources, and Adaptive Decision Support. For more information on Drs. Graff and Spring, along with a link to the complete program including interactive patient cases, patient resources, and online registration for an upcoming live program on this topic, please visit the show notes of this episode. Now let's hear what the experts have to say on first-line treatment for HER2-positive metastatic breast cancer.
My name is Dr. Laura Spring. I'm a breast medical oncologist at Massachusetts General Hospital in Boston and at Harvard Medical School.
And I'm Dr. Stephanie Graff. I'm a breast medical oncologist at Brown University Legarreta Cancer Center in Providence, Rhode Island. And we are honored to be here together today with Clinical Care Options, talking about advanced precision care and shared decision-making in first-line HER2-positive metastatic breast cancer management. Dr. Spring and I are going to be covering a lot of ground. And Laura, I think we agreed we're just going to be Laura and Stephanie today while we're talking, right?
Yes, that sounds good.
I think one of the exciting kind of things that came out through 2024 was really looking into the role of trastuzumab deruxtecan for patients with HER2-positive breast cancer. Dr. Nancy Lin presented the results of Destiny Breast 12 at San Antonio this year. So Destiny Breast 12 was a multicenter, single-arm, two-cohort study that accrued patients who had HER2-positive metastatic breast cancer that had previously received 2 or fewer prior lines of therapy. Patients were eligible if they had brain metastasis. It also did include a cohort of patients who had no brain metastasis for comparison, but it was non-randomized, and all patients received trastuzumab deruxtecan at 5.4 milligrams per kilogram IV every 3 weeks. And the primary endpoint in the brain metastasis cohort was progression-free survival, and the primary endpoint in the no brain metastasis cohort was objective response rate. Secondary endpoints did include things like central nervous system, PFS, and overall survival. So lots of interesting data was presented. At San Antonio, we saw the results of the overall progression-free survival in the group that both had and did not have brain metastasis at baseline. And we saw that progression-free survival was similar to what we've seen with other trials looking at trastuzumab deruxtecan for patients with HER2-positive metastatic breast cancer, with a 12-month PFS of 61.6%. The PFS in the brain metastasis cohort was similar at 58.9%, which was reassuring. The overall survival and the objective response rate in patients without brain metastasis at 12 months was 90.3%, which was wonderful. Really high objective response rate, 62.7%. But then when they sort of got into the details of how patients with brain metastasis responded, we did also see that there was a really great response in the CNS. And I think that seeing that CNS response really offered me a lot of confidence in a clinical setting that for my patients with brain metastasis, trastuzumab deruxtecan is a very effective therapy that likely crosses the blood-brain barrier and offers good clinical control for those patients. So I think before we had seen this sort of splitting in big national guidelines, whether it was ESMO or NCCN, where for patients with brain metastasis based on HER2 climb, there was some discussion about perhaps going to tucatinib in that patient population in that second line setting. But now I think that given the body of evidence for HER2-positive metastatic breast cancer, even in the setting of brain metastasis, I feel very comfortable utilizing trastuzumab deruxtecan, unless, of course, there's another indication, perhaps interstitial lung disease, that would drive me toward choosing tucatinib-based therapy. How has your practice been shaping up, Laura?
Yeah, I completely agree. I think seeing this similar PFS in the group with and without brain metastases was very reassuring. And that algorithm was always one of debate, which way to go. And I think with how impressive this drug has been, for response rate overall, this was very helpful data and helps, support its use in the earlier lines.
Another thing that's interesting is, of course, Dr. Lin did get a question from the audience about the risk of radionecrosis with radiation relative with trastuzumab deruxtecan. ADCs have been associated with that. And she had said in her practice that traditionally they've been waiting 3 to 4 weeks after radiation prior to starting, or try to create that space. That's what we've been doing as well. Of course, if we have a small or clinically asymptomatic brain metastasis, I do think it's okay to omit radiation or do surveillance with brain imaging, but some patients prefer still to do stereotactic radiosurgery. Obviously, we've got fantastic radiation oncology techniques that often patients are amenable to both options, combination therapy. How have you guys been approaching that?
We've been doing something very similar and, not doing the drug concurrently with radiation. I think we have more published data with T-DM1 showing the radiation necrosis risk as well. So I think there's a concern that we would see the same here. I think that there's some debate on exactly how long to wait. Obviously it is a drug with a long half-life. We've had some situations and more urgent cases where there's been some debate, systemic therapy first versus, can we do radiation first, which is what we traditionally would do. And there, I think we sometimes debate, doing it a little shorter afterwards. But I think especially if you were to treat with T-DXd with someone receiving it in advance with a long half-life, it's trickier because it would be on board unless you wait a bit before doing the radiation.
Yeah, so I think all of this complexity about how to approach particularly oligometastatic brain metastasis lends itself well to interdisciplinary teams. I know we're going to have a case coming up that our audience hopefully will join us and participate in online. So check that out, and you can participate in our case and share with us how you would answer questions like these. What do you think the role of tecotinib is? Do you think that tecotinib is just now our standard third-line therapy?
So that's, I think, a difficult question as we think about if T-DXd moves to the first line. And then,
well, I mean, right now we'll say we're still Cleopatra, T-DXd.
Right now, I think I view it as a more solid third line. I think the combination with capecitabine and trastuzumab is, obviously it's tricky with, 2 oral drugs and IV, but capecitabine does have some CNS activity as well.
Yeah.
So I think also maybe generation of real world data on the efficacy of the HER2 climb regimen after T-DXd. I think there's some initial data in that space available, but it'd be interesting to see that. In my own experience, I've overall just gotten more mileage out of T-DXd, even for, with the CNS disease than I have with the HER2 climb regimen. And I've also, though, had patients who have tolerated the HER2 climb regimen much better than T-DXd. So I think, when we talk about biomarkers also, more predictive biomarkers regarding things like ILD and tolerability. Another study I'd really like to discuss with you today is the PATINA study. So this was another really interesting presentation at San Antonio. And this was a open label phase 3 trial that looked at the addition of palbociclib to anti-HER2 therapy plus endocrine therapy versus standard anti-HER2 therapy plus endocrine therapy in those with hormone-receptor positive, HER2 positive metastatic breast cancer. So these are patients who were essentially in the first line, with the exception that they got their initial induction chemotherapy. So typically 6 to 8 cycles of trastuzumab plus minus pertuzumab with a chemotherapy partner, typically a taxane. And then typically in standard of care, we drop the taxane or the chemotherapy backbone and then continue on with HP indefinitely until progression or changes in goals of care or side effects. And in this interesting study with the endocrine therapy portion, the CDK4/6 inhibitor palbociclib was added at standard dosing, 125 milligrams daily, days 1 through 21, with it followed by a week off. And they continued on this until progressive disease or toxicity. And the primary endpoint was progression-free survival by investigator. And we saw overall a significant improvement in the median progression-free survival, I believe over 15 months, favoring the addition of palbociclib. Stephanie, when you heard this result, were you surprised? What was your first impressions?
Yeah, I really loved Dr. Hurwitz's, I started to say editorial. She was the discussant after Dr. Metzger presented this. And and pointed out appropriately that these patients were already sort of selected in that they had not progressed the triplet of chemo plus HER2-directed therapy and had been able to de-escalate, for lack of a better word, to the HER2 therapy alone, which already was telling you that these are patients that were performing well. Most of them had had a clinical response. And so that sort of point that you're able to say, okay, we can drop off the chemo, you're doing great. You've already selected a good group of patients. So this really, really good endpoint may be in part related to that. But I loved seeing these kind of numbers come out of a metastatic breast cancer trial. And my immediate reaction was that this is immediately practice changing. I started running a list in my head of patients I would want to reach out to when I got back to clinic after San Antonio. And it was exciting to see because it was, a trial that actually was difficult to accrue to nationally. So it's a good moment for all of us to reflect on how valuable this cooperative group research is and the role that studies like this play in helping us advance the standard of care in our field.
Agree completely. I think it was really nice results to see. But as you point out, this is a population of patients who often will do very well for years, which is great, can be on, HP for several years. So I guess I wonder a bit, and hope there'll be some maybe follow-up analyses trying to really pick out what are the patients that benefit the most from this strategy. On the other hand, it is a pretty well-tolerated drug. I think we all find that. And obviously there's the opportunity for dose reductions when needed as well. But I, assume they have some interesting translational analyses planned. So maybe we'll learn more from some, sub-studies in the future.
Yeah. And I did see sort of also in the aftermath of the presentation, I saw on social media some patients and some clinicians were asking about other CDK4/6 inhibitors. And I would just say, no, not yet. Of course, the other CDK4/6 inhibitors outside of palbociclib do have some unique cardiotoxicity that, outside of the context of a clinical trial, actually have black box labels from regulatory agencies that they should not be combined. And, drug-drug interactions are a real problem in our field that we have to consider carefully. So, Laura, one of my questions is really kind of in the context of PATINA, building on that for you, is I think PATINA has such, to me, again, immediate impact. So how are you thinking about moving T-DXd to the first line?
Yeah, I completely agree. I feel like I give it like candy, but it is not candy. And I wonder if we're going to see folks do their own induction strategy. They're like a Cleopatra model of 6 to 8 cycles. Because even I have a group of patients who tolerate it very well. But as you said, like after time, it just gets tough. These people have been on this agent a couple of years. It really just gets so hard. And, these are some of my most enjoyable appointments sometimes, are patients on HP for years. So I don't think we as a breast oncology community can really imagine giving it indefinitely. So maybe there'll be enough sort of push for, I would love to maybe see a trial using it in that induction setting. I'm sure they, maybe they'll want more than 6 cycles, maybe a little bit more, and then actually doing a PATINA type approach, like to see that in sequence.
So I know another case that we'll be talking about at our upcoming webinar is specifically asking about some drug-drug interactions. So again, just a little teaser for everybody to check out our upcoming webinar on first-line HER2-positive metastatic breast cancer to think through some of these issues with us. But, considering both the patient takes for their standard of care drugs and how our cancer therapies interact with each other is always an important part of what we do in the art of oncology. I hope we'll see you at that webinar.
Yes, please remember to tune in for the webinar on discussion of first-line therapy in HER2-positive MBC.
Thank you, Dr. Graff and Spring, and thanks to you, the listener, for joining us. As a reminder, to view the full program, Advancing Precision Care and Shared Decision-Making in First-Line HER2-Positive Metastatic Breast Cancer Management, expert insights, patient resources, and adapted decision support, and to register for an upcoming live webinar associated with this discussion, please click the link in the show notes. As always, thanks for listening.